Treating hepatocellular carcinoma, or HCC, presents a unique clinical dilemma. Physicians must fight a lethal malignancy while simultaneously managing the patient's underlying chronic liver disease. Because of this dual pathology reality, deciding how to treat the cancer is rarely a simple binary choice between resectable and unresectable. Instead, patient care is dictated by rigid algorithms, most notably the 2022 Barcelona Clinic Liver Cancer, or BCLC, staging system, and the American Association for the Study of Liver Diseases guidelines. The BCLC system is a framework that categorizes patients into 5 stages, based on tumor burden, liver function, and physical status, to recommend specific clinical treatments. Moving a patient along this pathway relies entirely on meeting criteria at strict gatekeeper checkpoints, based on tumor burden, background liver function, and vascular anatomy. These gatekeepers are defined entirely by the radiologist's assessment using cross-sectional imaging like CT and MRI. We are going to navigate this treatment matrix and decode how microscopic and macroscopic anatomical variables strictly dictate eligibility at every major node of the BCLC system. In modern HCC management, precise anatomy serves as the absolute gatekeeper to a cure. We begin on the BCLC matrix at stage A, the early stage of the disease, where surgical resection is the preferred curative intent for solitary HCCs. In early-stage disease, surgical eligibility is dictated less by the size of the tumor and almost entirely by the future liver remnant, or FLR. The FLR is the calculated volume of healthy liver tissue that will remain after the surgeon removes the diseased portion. In a patient with a completely healthy non-cirrhotic liver, a minimum of 20% FLR is required to prevent postoperative liver failure. The problem arises because HCC primarily occurs in cirrhotic livers, altering the organ's ability to regenerate. The FLR minimum requirement scales directly with the degree of chronic liver disease, jumping to 40 or 50% in patients with severe F4 stage cirrhosis. Beyond volume, the presence of clinically significant portal hypertension, or CSPH, acts as an absolute hard stop for open resection. CSPH is defined as a hepatic venous pressure gradient of 10 millimeters of mercury or higher, indicating severe resistance to blood flow through the damaged liver. Since direct pressure measurements are rarely obtained, radiologists actively look for surrogate anatomical signs on CT, specifically an enlarged spleen, fluid accumulation known as ascites, and swollen portosystemic varices. If CSPH is present, the patient is diverted away from an open hepatectomy and routed toward alternative locoregional therapies or minimally invasive surgical approaches, such as laparoscopic or robotic techniques. The radiologist's precise calculation of the FLR and their identification of CSPH directly determines if a patient will survive the operating table. This raises a critical clinical problem. What happens when a patient requires a right hepatectomy, but their cirrhotic liver cannot meet that strict 40% threshold? Interventional radiologists bypass this limitation using portal vein embolization, or PVE. PVE is an adjunctive technique used to artificially induce compensatory hypertrophy, or growth, in the FLR prior to surgery. By deploying embolic material to intentionally block the right portal vein, blood flow is diverted away from the tumor-bearing lobe and forcefully rerouted into the left lobe, stimulating it to swell and grow over several weeks. The success of PVE relies on flawless preoperative mapping of the portal venous anatomy, since up to 35% of patients possess structural variants. Let's analyze specific, high-risk portal vein variants that disrupt standard surgical assumptions. This CT scan shows a trifurcation pattern variant present in roughly 9% of patients, where the main portal vein splits simultaneously into the right anterior, right posterior, and left portal veins. An even higher risk structural anomaly is the Z-shaped portal variant, found in 13% of patients, where the main portal vein bifurcates into the right posterior pedicle and a shared common trunk for the right anterior and left portal vein. The Z-shaped pattern introduces a severe surgical risk during a left hepatectomy. Inadvertent ligation of the left portal vein at its origin will accidentally cut off portal flow to the completely healthy right anterior sector, specifically segments 5 and 8, resulting in unintended tissue death. Recognizing these exact variants dictates whether the interventional radiologist must perform separate, highly selective embolizations during the PVE procedure to safely route the blood flow. In the context of hypertrophy and staged hepatectomies, a single unmapped vascular branch can turn a curative procedure into a fatal complication. Moving to stage B on the BCLC matrix, tumor burden exceeds resection criteria, and transarterial therapies like TACE and TARE become the frontline standard. TACE stands for Transarterial chemoembolization, which delivers chemotherapy directly to the tumor, while TARE uses yttrium-90 radioactive beads to destroy the tissue. Navigating these transarterial therapies shifts the anatomical focus away from the portal vein and directly onto the hepatic arterial supply and venous outflow. Variant hepatic arterial anatomy heavily dictates the procedural approach, starting with the replaced right hepatic artery originating from the superior mesenteric artery, or SMA, found in roughly 4% of patients. The SMA is a major blood vessel that typically supplies the intestine, not the liver. A replaced artery alters the catheterization route, requiring access via the SMA rather than the celiac artery. However, it is highly favorable during surgical resection. Its separate origin physically protects the future liver remnant's blood supply from accidental injury during hilar dissection. We must also map the venous outflow, specifically looking for the accessory inferior right hepatic vein. Up to 40% of patients possess this variant, which drains segments 6 and 7 directly into the inferior vena cava, bypassing the main hepatic veins entirely. The inferior vena cava, or IVC, is the massive central vein that carries deoxygenated blood from the lower body back to the heart. Failure to identify this vein during a TARE procedure can result in severe, unintended shunting of radioactive yttrium-90 directly into the patient's lungs. To safely deliver the radiation, interventional radiologists must proactively perform temporary balloon occlusion of this accessory vein during the procedure. Transarterial therapies are only effective if the radiologist can map both the obscure feeding arteries and the hidden escape routes of the venous outflow. The final curative node on the BCLC map is liver transplantation, managed by the United Network for Organ Sharing, or UNOS. UNOS coordinates the United States organ transplant system. This option is reserved for early-stage HCC with poor underlying liver function that precludes resection. Livers are allocated on a sickest first basis via the Model for End-Stage Liver Disease, or MELD, a scoring system predicting survival. HCC patients rarely reach a high enough MELD score naturally before their cancer progresses too far to effectively treat. To prevent patients from dropping off the waitlist, the system awards MELD exception points to prioritize them. Obtaining these points is governed by ruthlessly strict size thresholds. This animated MRI scan shows the most critical radiologic measurement in transplant oncology, the rule requiring a solitary HCC to measure between 2 and 5 centimeters. This creates a highly counterintuitive protocol for a solitary HCC under 2 centimeters, the wait and not ablate approach. These patients are explicitly denied exception points due to a high rate of false positive diagnoses and a low risk of waitlist dropout. Patients are forced into active surveillance, requiring imaging every few months without intervention. A single millimeter of growth changes their trajectory. Once the tumor crosses the 2-centimeter threshold, exception points are granted and a mandatory 6-month radiologic stability clock begins. At the transplant node, a radiologist's precise measurement of a single millimeter directly determines the trajectory of national organ allocation. Because HCC management is a rigid multidisciplinary matrix, the traditional narrative-style radiology report is clinically insufficient. Institutions require a structured anatomy-based reporting template, like the one utilized at Stanford University, that aligns perfectly with BCLC and surgical dependencies. Aggregating specific data points, tumor burden, background liver status, and critical vascular variants instantly triages the patient down the correct algorithmic pathway. This structured data directly empowers hepatologists and surgeons in a multidisciplinary tumor board setting to make immediate, safe, and curative decisions. By translating raw imaging into actionable algorithmic data, the radiologist serves as the essential architect of the HCC treatment plan,